and we should be able to complete this in the next few coming months. And we're happy that Dr. Lazarus, who is in charge of the care and treatment team, is part of the team that is here today, and he'll also just maybe share a few highlights as we'll be going through the differentiated service delivery section. But what does it take for us in terms of just being able to characterize our clients? Like, for example, once you initiate the clients on ART, are we recording the time that we are doing the viral loads for the clients? Are we able to record this by county? Are we able to record this by partner from the time the clients are initiated on ART to the time that they get their first viral load? So that is one of the highlights that we'll be taking you through today. In the service delivery, differentiated service delivery models, to just highlight, you know, that DSD, as for us as a country, is one thing is that it's not a one-size-fits-all for the clients that we currently have. And when the current guidelines that we had, we used to characterize our clients in terms of, are you a stable client, are you unstable clients, then you know what type of model we move you into. But with the new guidelines that are being revised, you know that there might be a few changes here and there. And differentiated service delivery has really been key for us as a country in terms of being able to support lifelong adherence, especially for the clients that we have. And it has been good for us in terms of saving costs. Also, it has been convenient for most of our clients, and also when you look at it in the long run, not only has it saved costs for us and has it been convenient, but it has also been efficient in terms of time. And as Lazarus will also be sharing, we'll be able to see the different types of service delivery models that we have, like, for example, facility-based, community-based, and how are we faring as a country, and also just looking at it, is it in terms of also healthcare worker-led and also peer-led, how is it that we are faring as a country, and looking at the coverage of differentiated service delivery models. So this is all lined up for us, especially today, as we'll be talking about differentiated service delivery models. We'll also highlight in terms of the coverage that we have, the number of clients that we currently have under the different service delivery models, and also looking at, are we able now to move to the next level when it comes to DSD in terms of impact? For example, are we able to move further and see how is viral suppression like for clients who are on different service delivery models, and what proportion of our clients on different service delivery models are we actually retaining in care? So it's always good for us to be able to assess that impact. And for us to do that at the different levels or areas where we are working, then it is important for us to be able to understand how we compute this in the national data warehouse, and how is it that we have been computing, so that we're also able to correct the errors that we have. Are we looking at 90 days? Are we looking at more than 90 days? This is all very key and critical so that we have common understanding. And whenever we share data on multi-month dispensing, then it is very clear for you. You know, as government right now, we have been facing a few challenges here and there, but we still retain that as we look at our commodity supply chain, that we are actually able to continue with the recommended 3-month, multi-month dispensing that we currently recommend, especially during this period of COVID-19, due to the supply chain and the number of commodities that we have as a country. I know previously we had clients who were on even 6 months, multi-month dispensing, but the key recommendation for now is that we retain it at 3 months, multi-month dispensing. So there will also be an ad hoc session where Mary Gikura will be taking us through it. And in this session, you'll now be given an opportunity to also be able to log into the system. It will be a practical session. You log into the system, and you'll also be able to see how are you able to generate your online list, how are you able to filter the data that you have, and how are you also able to download the data that you have so that you can use this data to do your own analysis, and also utilize this data to come up with your own charts that you can utilize for other purposes. And also, if you want to come up with high charts, you have downloaded a data, some data, and you want to utilize it, how then are you able to do this? And also, if you want to have your data by hierarchy, like for example, today we are a mix. You want to have your data by county, you want to have your data by partner. So this is all lined up for you. So it's an exciting session that we have today, and we're happy that you are here, and we hope that we'll continue with this to the very end. So at this point, I would like now to invite my colleagues who are here. I'll be waiting for a few of them to join, to just give a few remarks on behalf of the various agencies who are here in this meeting today. And I'll start with my colleague Brian Onyango from USAID to give some comments on behalf of USAID. Brian, welcome.
Hello. Yeah, thank you, Dr. Violet, and thanks everyone who is in attendance. I don't have much comment. I'll be able to make more remarks later at 10:45, but I just want us to be able to welcome us to this session. I think I look forward also to seeing the changes and the improvement, and also to see how we can be able to continue working together to improve quality, data quality, and as well as data use to inform our programming. So that's what I have for now. I'll be able to make additional remarks later today. Over to you, Dr. Violet. Thank you.
Thank you very much, Brian, and welcome. And we'll still give you an opportunity to make the remarks later. But we appreciate the support that we will get from USAID. On behalf of CDC, we have the surveillance branch chief, that is Dr. Anthony Waruro, who will give remarks on behalf of CDC. Dr. Waruro, welcome.
Hello.
Good morning, everybody. Thank you, Dr. Violet. I'm not actually the branch chief for surveillance, but happy to be here and join these sessions. We all know that the EMR, the systems we have at the facility level, and the National Data Warehouse are actually the sources for one of the main component of surveillance, which is case-based surveillance. So I've been attending these sessions and I find them quite enriching. Looking forward to this last session. Over.
861.
Thank you. Don't worry, Anthony, you are representing the surveillance branch from CDC, and also just giving remarks on behalf of CDC, and we appreciate your support. And I know as the surveillance team, this is where we really need to ensure that we continue tapping into as we get our data, because this is all the work that we do together. We are also happy and pleased that we have been joined by our colleague from UNAIDS, that is one and only Henry Damisoni, who has been very supportive of all of us, and we have all been looking at how is our data as a country, and UNAIDS has always come through in terms of just supporting us as government to ensure that this is actually done, even as we work on estimates, among other things that we do. Henry, please share a few remarks, and welcome. Please let's give Henry the mic. So,
hello, good morning.
Morning.
Yes, just to thank all of you for thanking NASCOP for organizing this meeting, and just like other colleagues have said, I'm also equally excited to be part of this webinar series, and I look forward to learning a lot, and hopefully together we can make it into making sure that the data that we generate is of value to everyone. So on that note, let me thank you and look forward to the deliberations. Over to you, Chair. Thank you.
Thank you so much, Henry, and feel very much welcome. We appreciate the support that we get from UNAIDS. At this juncture, I will now move to the counties, and we are happy to have Tom Kempua, a CHRIO from Kajiado, who has been able to join us, and we'll just request Tom, you kindly give remarks on behalf of the CHRIOs. Tom Kempua, if you can hear me.
Hello.
Okay, thank you so much, Dr. Aramnisi, for the opportunity to have us in this meeting. And on behalf of the counties, and specifically the CHRIOs related to this meeting, I know for the CHRIOs and the HRIO fraternity are actually the ones who generate most of the report we shall be discussing here. And it is our pleasure to have a discussion on whatever we are doing in these counties and these HRIOs. And at this juncture, it is very paramount that we look at the data we are using for decision making, so that it will be data which can make sense and it can be used to make informed decisions. So on behalf of the CHRIOs and the counties, we are happy that we are discussing this data, especially during this pandemic period, where most of the routine activities, including the HIV activities, are endangered because of the restrictions and the infections which are still going up. And I think by the end of the discussion, we shall have a fruitful discussion and way forward on the management of the HIV program in Kenya. Thank you so much.
Thank you very much, Kempua, and as you put it correctly, very important for us to look at this data, and we really appreciate the CHROs, especially the fact that we have been looking at the data together, and at this time, a lot of data quality issues as government and also as and I think the way we are collaborating together, we need to continue this way so that we can continuously look at our data and be able to sort out the data quality issues that we have. I will now proceed to invite the chair of the CASCOS to also share remarks on behalf of the CASCOS from counties. Dr. Mike Kisa, welcome.
Thank you, Dr. Violet. Just confirm that you can hear me.
I can hear you loud and clear.
Thank you, Daktari, and good morning, everyone. We are glad to be here as we tend towards finishing up this series. Thank you, Tom, for joining in, and personal regards to Team CHRIOs for the good job. Just starting from there, that we now know we have 1.2M plans on ART, courtesy of a good job done by our HRIOs to report this monthly. Each of those plans is tallied daily and submitted monthly to a summary tool. So thank you, Team CHRIOs. On this matter, Doc and colleagues and the stakeholders here, we celebrate the growth of EMR in Kenya, and we know that our epidemic response has really grown, and at this point where resources is becoming a challenge. Of course, from the counties we have the benefit of being in touch with the ground. On Monday I was in our general hospital, SCCC, and one of the real challenges there is with a growing program where everyone ART should now be above 10,000, plus 20. You want to imagine the challenge in space of storing those files and the resources in buying more hard copy materials for record keeping. I think we all can't overemphasize that EMR is overdue and is the way to go, all the chain up to the DWH system. And much more from a clinical background, we have a growing need to do longitudinal follow-up of our clients, both for surveillance reasons and for individualized patient care, even as we now talk of differentiated service delivery, which really is client-specific service delivery. The one way to achieve this is through a working robust EMR. And further, I know the need that we can't sweep under the carpet unique client identifier to allow us to do inter-facility interop of systems. We know that one of the doubts we have on our case current numbers is on whether they belong to a unique client or the application across. Of course, we keep witnessing this through Our retention, which stays at 70 to 80% at 12 months, just suggesting that most likely our clients might be showing on the other side as new. So we pray that we soon reach where all our clients can be on DWH. Another challenge on new doc and the team. Now that we are 80% covered by EMR, how about innovations like what we are doing with EHTS with lesser resources to reach the smaller sites that carry the 10% across the care as well as HTS. So there's still some work to be done, but we are ambitious and we are very optimistic of this. So we look forward to the final part of this. And finally, the challenge that probably we'll need more and more of this in view of the competing tasks in this season. Definitely not all our target group has reached this webinar, and we pray that this will be recurring, both in this Zoom version as well as in a digital learning platform. On behalf of the task force team, thank you for your support to the counties, and we look forward to continue partnering to reach out HIV care to our PLHIV, as well as step up prevention for our millions of population. Thank you to all stakeholders, and over. God bless you.
Thank you very much, Dr. Michael Kisa. We always enjoy working with the counties, and thank you even for the request that you've been able to pass across. And especially just looking at one of the key highlights that you have been able to mention, the fact that when we look at our EMR coverage currently as a country, we have about 80% of our clients who are those who are currently on treatment getting their data through our EMRs. And we have a very small percentage of those who are currently on treatment that have not yet been covered. And one of the things that I think it's good for us to say here is that currently we are all thinking through innovative strategies, especially when it comes to use of digital health solutions, for us to be able to scale up, especially for our clients who are not on EMRs, on how we can be able to utilize the digital health solutions to be able to also get their data. One thing that we need to also see is that as we are going through this series of webinars, you can see the magnitude and the quality of data and you know, the richness of data that we are getting through the EMR system, which is something that we really miss when we do the aggregate level reporting for our data. And this should actually challenge all of us towards a direction that how do we scale up the EMR systems that we currently have at the various counties, especially for facilities where we have more than 200 clients. How do we ensure that even as counties we are able to invest in ensuring that, one, we have sustainability of what the partners have invested in, and again, they are able to scale up EMR solutions to other sites that we have within our counties. And I think it's a very good challenge, and we take it up not only as national government, but also as county governments. How do we move this to the next level? Because we are taking us through this so that we can be able to be challenged and to also enjoy the richness and the beauty of having quality data and having a lot of data for available for us to be able to use as policy makers, because we are all policy makers at different levels where we are working. So this is really good for us as a country, and we have put in a little effort, and hopefully in the next grant, as we had put it, we hope that we'll be able to especially scale it up for national government, those who are not PEPFAR supported, to support this scale up, especially in the ASAL sites. But I also want to challenge our partners, especially from PEPFAR, that let's scale up EMR, especially in counties where we are supporting, and we can see the volume of clients that we have is growing. So let's take up the challenge, and as the SIITT, let's see how do we invest more, especially when it comes to digital health solution. It saves us a lot when it comes to especially finances that we utilize most of the time to print tools, and we can be able now to see making it open source, benefiting from community of developers, and it is really good for us as a country. But meanwhile, we all open up our eyes and look for resources to be able to scale this up to the next level. And we will not stop the series of webinars today. We just want to inform you early enough that we plan to continue, because we have been able to reach a large audience, and most of us from the few series that we've been able to hold have told us that we do not want this to stop. So we can assure you from the beginning that we will continue and we will have more information to be able to share with the counties, with our partners, as we all interact with the data that we are generating as a country. Data use is critical for us, and we will continue emphasizing on the importance of us utilizing the data that we have, because the more we use the data, then the quality of our data will get better, and even the decisions that we make for our country are actually going to be better decisions, and eventually we'll have very good information products that we'll be able to get from the data that we have been generating. So thank you very much. And now to the other logistic bits, to the county teams, the CHRIOs and the CASCOs, please register. There's a tool that will be shared by one of our colleagues, a link that will be shared for you to register. We will reimburse you bundles for attending the meeting today, and also for the other series of meetings that you were able to attend before. We were not able to reimburse before, but for today's session, we'll reimburse all of you your airtime bundles at the end. After the meeting and you have done the registration and the logistics have all been done, then you'll get your airtime reimbursement for participating in this meeting, and we appreciate the fact that you're able to stay through this meeting. So please ensure that you register in that particular form. So at this juncture, I now want to hand it over to the moderator of the session today, who is moderating this particular session, Franklin Sombok, and we also appreciate the support that we've been able to get from you. I also want to take this opportunity to really recognize Palladium. Sombok, as I hand it over to you, Palladium, one of the HIS partners that we work with, because we have really worked collaboratively with NASCOP to ensure that this work actually gets moved to the next level. So Palladium, thank you for supporting government to move this to the next level. And also thank you for supporting all the partners to ensure that we are actually at par as we move this to the next level. I think most of the people are enjoying the series that we are currently having, and it is really good for all of us as a country. Let's continue collaborating together as government and also as partners as we move, especially the monitoring bit of this epidemic to the next level. Thank you very much. Everybody feel welcome. It's an open session. Ask many questions in the Q&A session, which I have not seen anything floating so far, but as we start the presentation, utilize it. Ask as many questions as you can, because this helps us improve on what we have, and we are able to move to the next level. Sombok.
Thank you very much, Dr. Ramisi. We really appreciate your support. And because of time, kindly allow me to quickly take you through our agenda today. So I think we are done with the first part. So we will now jump into our next session. So and we'll just look at a bit of a background, and we will focus much on the DWP bit, because I remember last week we were able to give you an update on the new DWP, and the expectation is that we wish that all the facilities, with the support of the county teams and the partners, update their DWP so that they are able to upload their data using the new DWP. So we will give you the current status in as far as how many facilities are still using the old DWP, and I think we know the benefits of the new DWP. So we would really wish that at the end of this meeting, kindly let's be able to let's try as much as we can to ensure that we update our DWP. Then we will then go to the Dsd bit, so that we will have our session one, just like Dr. Misi had already mentioned, and Dr. Momani will be able to take us through that part. Then we will go to the Addock section, and I'm hoping that all of us are able to access a laptop or a computer, because this session will really need some hands-on experience, and I'm hoping that we have all the stewards from the various institutions and organizations, so that they're able to approve the login, because for you to access the DWP a bit, you definitely have to have the login credentials. So we are hoping that the stewards are in, so that they can be able to support us in that particular part. So Mary today will take us through that particular part. Then we will go to the plenary session, and Brian Onyango from USAID will take us through the plenary session, and then we will finally go to the remark session, and we will have the various agencies and institutions to be able to give their remarks, and finally we will close. So the first part I'll be chairing, then once I'm done, I'll be able to hand it over to Dr. Nyanya, who will chair the next session to the end of this webinar. So thank you very much. So kindly allow me to call upon Faith Ngani to take us through the background. Faith Ngani, take it up, and let me stop sharing the screen. Thank you, and Karim.
Thank you, Franklin, and good morning, everyone. Allow me to share my screen. I will just give a brief background, and as my colleagues have already alluded to this, it's just a session to look at what we have been discussing in our previous series, because we are growing with time, and I think it will be important for everyone to be able to make correction where there is need, and to be able to improve on areas that haven't been improved. So Songok, confirm you can be able to see my screen.
Yes, Faith, I can be able to see. Just proceed. Thank you.
Okay. I will not echo what my colleagues have already said, that today's session is going to just have a bit of background where we are looking at areas of improvement. And then we are going to have an introduction into the ad hoc section. I must say it's a very exciting session. And as my colleague has said, it's a hands-on session where all of us really need to ensure we have our laptops or a gadget that we can be able to manipulate to access data. This webinar, as my colleague Dr. Oramisi has said, is courtesy of all of us. So it is a joint effort between the Ministry of Health, the USG Palladium, and other stakeholders. That is the reason why we are here today, and we can be able to share the work that has gone into making in the National Data Warehouse. And so we really appreciate the efforts by all of you. Just to ensure that we are well and professional in our undertaking this webinar, kindly when you have questions, utilize the Q&A session to put in your questions there, and the team on board is going to be able to respond. But for the areas where there is something burning that you need to speak about it, we will have a session called plenary, and at that time we can be able to listen to some of the concerns and clarifications that you would like to seek from the team. So I'm not going to echo what my colleagues have already said about what our session contains today. It has two sessions, not three. We're going to be looking at the DSD and ad hoc section. The 3 is because we had something else to do, but once you interact with the ad hoc section, you will see that it really needs a lot of time. And that's the reason why we have been able to just keep it at 2, to make sure that we all understand, especially the introduction bit, as we move and plan for a more detailed session on the ad hoc section. So for those that did attend last week, we had a session where we were looking at the DWP, where we were releasing the new DWP tool. And we did release the version 2.6.0, which is now the recommended one. And we got to see the insight which this tool has and what it can do in regards to accessibility of data from the National Data Warehouse to the National Data Warehouse from the EMRs. And what I'm sharing on my screen is counties that are still using the very old DWP tool, which if we continue doing our analysis and probably improving on our dashboards, we will not be able to get some of the variables that are required. So you can be able to see that we have 45 facilities in Nairobi that still have DWP tool version 2.4.8 and below, and that means that we are not able to get all the necessary variables from the EMRs that are in Nairobi. It is closely followed by Laikipia, Nakuru, Kajiado, Busia, Uasin Gishu, Moranga, and the rest, as you can see. But it's also good to appreciate our colleagues from Bomet, Homa Bay, Kiambu, Kirinyaga, who have been able to ensure that they have updated at least to the version that was there prior to the version 2.6, which was version 2.5, and I'm certain that these counties and the partners on the ground are working to ensure that all the facilities now move to version 2.6. If you look at it per partner, you can be able to see we have a lot of facilities that are being supported by Afya Nyota ya Bonde that are still using the old DWP tool, and our plea to the teams because I know all of us are here on this presentation from each of the IPs on the ground, is to make sure that kindly let's update our facilities to make sure that we are using the latest DWP tool. As it was presented by my colleague from Palladium last week, the new DWP tool is more exciting and is able to capture most variables. And as a program, we have a lot of requests to improve on the dashboard to give aspects of TB HIV. And if you remember, that was not being captured, or it was not being captured during using the older DWP tools, but now we have been able to improve this with the latest version. So the recommendation, we are not presenting this to display faults, but it's to ensure that we are able to improve and that we are at par. And I think it's something that we shall be doing continuously, so that at least all of us are able to catch up with the current status. And the recommendation by the team is that kindly reach out to us. We shall be able to assist you if you have any challenges. Remember, we have walked the path of migration together, so even this is just something small, and we can be able to work together as a team and ensure that we are all at par. So in case there are any challenges that you're facing on the ground, I'm sure there's a help desk number that you've been reaching out to our Palladium colleagues. But even for us as NASCOP team, we are available and we shall be able to resolve. And I really want to appreciate all of you. There've been hitches even around integration, and specific partners have reached out to us and we have been able to make corrections. So do not shy off, just reach out. We shall be able to assist all of you.
0800.
And then during the presentation as well last week, we looked at the median time to a VL after starting ART, and we discovered that there are some counties that have a median time of about 1 month, and others are even below 6 months. And it was something that we raised. Probably it's an issue in regards to data quality. Like you can be able to see that in Embu County, they have 37 patients with a median time of 3 months, while Bomet County has 22 patients with a median time of 1 month. So you remember we do our VLs depending on the category of patients. There are guidelines, but I know the list would be about 6 months, especially for pregnant mothers. And then we also have other categories. But to be able to understand this data better, we did an elaborate analysis. Okay, this is by partner. You can be able to see which partners are supporting these counties in regards to the data support and completing the forms. And as I say, probably it is a data issue. So the best thing would be to go back to the numbers that have been displayed, and I'm certain, this being an EMR data, we have a line list of patients and we can always be able to go back and make corrections. So for our colleagues, our IPs who are affected by this, kindly just go back to your sites and identify which site has this data. If it's an issue in regards to recording, kindly do make the corrections. But again, if it's a justifiable case, we can always be able to discuss. We had some analysis that had been done to show the characteristic of these patients, just to be able to let us know, could they be children, could they be expectant mothers. But from the analysis we did discover that all of them are above, majority of them actually are above 14 years. So these are in the adult category. And further we plan that in the next session, we shall be able to validate them further and identify who they are. But I believe with time, this will have improved. So hopefully by the time we are having our next webinar series as planned, we will see this improve and we will now be able to analyze the few that will be remaining. So thank you very much for this session. As they say, it's not a fault finding session. It's a session to just highlight some of the gaps that we are discovering from our data, and this could be affecting part of the analysis that we could be doing. This is how we are all supposed to access the National Data Warehouse, and I think it's something we all are now aware. So as we get ready for the ad hoc session, because there'll be something like a login, kindly just get into one of these access links And then the session will, once the presenter is ready for presentation, you will be able to have the login, right, so that you can be able to continue with the ad hoc session. Thank you very much, Songok, and over to you.
Yeah, thank you very much, Faith, for taking us through that first bit. Just looking at the background, and I think it will be very important for us to ensure that we update our DWP to the new version. And in the last week meeting, I think all of us were able to appreciate the beauty of updating, because of updating our DWP, because it will enable us to be able to upload more variables than we would if we were to use the old DWP. I can already see some reactions in the chat from various teams. We know that there have been changes in terms of the service delivery partners of the various teams. So I can already see some reactions from Kajado, from Lamo, and the rest of the teams. So I think we will be able to revisit that and be able to speak into that in depth later on during our plenary session. But we appreciate that fact. But we also urge you to work closely with the new partners, the new service delivery partners, to ensure that you are able to update. And like Fred has said, just in case you have any difficulties or any issues, kindly reach out. We will be able to support you to ensure that you update to your new DWP. So thank you very much, Fred. And kindly let's utilize the chat section. Let's keep asking our questions. The teams from NASCOP and Palladium will always be available to respond to any of your questions. So so without wasting much time, this is on our side. So kindly allow me to hand this over to the next presenter.
Yes, hello.
We'll take up the next.
Good morning. How are you?
The next sessions.
Yes, this came from Palladium Service Desk.
Take it up, Dr. Winnie.
Yes, Georgina.
Thank you, Songok. Thank you for the beginning part of the session, and also Faith for your background on what we discussed last week. I want to say good morning to everybody. For those who don't know me, my name is Dr. Winnie Nyanya, working as a technical advisor in pediatrics and adolescents at NASCOP. Karibuni sana to today's session, and as has been mentioned, we hope it's going to be very interactive, and we anticipate participation from everyone. So without much ado, I would want us to go to the next session. I will introduce Dr. Momani, who will take us through the first session of differentiated service delivery. I would urge everyone to pay attention to this, because as has been mentioned, we'll have some of the changes that probably you've not seen in the current guidelines, but in the anticipated new guidelines, we are going to see some changes. So I'd want everyone to pay attention and ask questions so that you can be able to take them through the plenary session. Thank you, and welcome, Dr. Momani.
Help me their phone number.
Dr. Momani, if you're able to project and take the next session.
Can I get remote access to the server? What do you have? Any disk? Team viewer. Okay, let me just get a machine with team viewer.
Okay, let's reach out to Dr. Mani. Lazarus, and please.
Dr. Winnie, maybe I could hold brief for Dr. Lazarus as we wait for him to log in.
Okay, Dr. Mudoka, you can take over as I try to reach out.
Thank you, Dr. Winnie. Just let me know when he's on. Allow me to share my screen as well. So I hope my screen is visible. So I'll try to fit into the big shoes of Dr. Lazarus on DSD. And I think the presentation will begin by giving a bit of a background on why DSD and the background on the basis that DSD is a realization that is not ideal for the HIV sector, just like in other sectors, and there's need to tailor services to the needs and the priorities of the clients. So using this person-centered approach to be able to offer services, then we can be able to improve the outcomes of patients in ALT, and along the way this will be.
Yes, Dr. Violet, the presenter seems to be zooming in and out in terms of his audio. Can we get help so that we can enjoy his presentation?
Team view ID.
Okay. Dr. Mudoka?
Yes. Yes, I can hear you, Dr. Violet.
Okay. I think we're having a problem
just
with the audio.
give number, the ID and password.
We hear you on and off.
Okay.
Okay. Okay. Let me see what I can do with the internet. Is Dr. Lazarus back on?
Lazarus is not back on, but maybe if you need to be supported, then we can see how to support you with the presentation. Then you'll take us through the demo.
I've changed my internet. I hope it's better now.
Okay, we can hear you, but in case of anything, we'll update you.
Okay, thank you, Doc. So I was just talking about the reason why we need DSD and the benefits to the patient and also the healthcare system in relation to the cost, time, and also convenience for the patients. And just looking at the different types of DSD, the various models, that is either facility-based or community-based. And you can also have
Dr. Modoka, I think we still have the same problem.
Yes,
I think your problem is the microphone, not your internet.
Okay.
The problem is your microphone, not your internet.
Okay. And maybe you can ask for help.
All right. Okay. All right, so we'll proceed with the presentation. Dr. Modoka, you continue sharing your screen or I share from my end?
I can share.
Okay, I think I have. Can you see my screen now?
Yes, I can see.
You'll take us through maybe as you work on your mic or maybe change the mic, you'll take us through the demo and we can quickly run through the slides. Okay, so for the differentiated service delivery models, as Dr. Modoka has taken us through it, is the fact that one thing that we need to just emphasize is that DSD is one of the ways in which you realize that it's not a one-size-fits-all in terms of approach for differentiated service delivery services. And the treatment and care approaches for us as a country is that we tailor to the needs and the priorities that our various clients have. and it is specific to each individual. And you can also see from that picture that we have different clients who we serve as a country, and we need to just ensure that, it's a people-centered approach in the way in which we are offering the services to our clients, because we have clients ranging all the way from the elderly to the pediatrics, and we have to see how we are able to offer services to them. And the one thing we need to also know that about DSD is that its main aim was just to ensure that we're actually able to offer and lifelong support, especially when it comes to adherence. And the benefits that we have been able to get, especially for the clients that we serve, have been around cost, time, and also convenience for the clients that we have. So the Dsd models, we have the facility-based and the community-based. We also have the healthcare worker-led and also the peer-led models that we have. And in this we have multi-month dispensing, where we look at the refills, also looking at fast track. And as a country or as a government, you remember that from the guidance that we have been giving, we have emphasized currently on the 3-month, multi-month dispensing. And as I said earlier in the remarks, is that we have also been having 6 months, multi-month dispensing when it comes to dispensing or refill for the clients. We've also had fast track for the various clients who are on different differentiated service delivery models. We also have community ART groups, which are peer-led or healthcare worker-led. We have also been having family treatment support refill, community outreach, ART delivery, and we have had facility-based health provider managed groups, that is especially for the adolescent clubs and others. And there is also integration of models, the different models for clients, and as well as high viral load clinics. So when you're looking at the differentiated service delivery model data, one thing we need to know, or what do we really need to measure, especially when it comes to coverage and also impact, because at the end of the day, whenever you're doing something, you need to always ask yourself, in the long run, I'm looking at what am I going to get? That is now in terms of the impact. So we are asking ourselves, what the impact of clients on the differentiated service delivery model? We want to ask ourselves, how many of our clients in the different DSD models are currently virally suppressed? How many of them are retained in care? These are some of the things that we want to see and see how we move that to the next level. So that is looking at it in terms of coverage, in terms of impact, as one of the indicators that we need to measure for the DSD clients. When it comes to coverage for the clients that are currently on DSD, we want to just be able to know the proportion of clients that we currently have on ART and how they have been categorized. To remember that in the earlier slide that we shared, we had different clients, different ages, so it's good for us to be able to know that. Then it's also good for us to know how many of them are well, how many of them have advanced disease, and also looking at it in terms of the stable versus the non-stable clients, and also looking at the proportions of stable clients on differentiated service delivery models. And looking also at model mix, what proportion of our clients are actually on model mix, and also looking at the coverage in terms of multi-month dispensing, the number of clients that are on multi-month dispensing, and also looking at it in terms of 3 months, 6 months, or any other multi-month dispensing that we currently have as a country. So these are some of the indicators that we measure as for the differentiated or for DSD data. When it comes to multi-month dispensing computation, this is where we have had people computing it differently. So we have some computing in terms of, most of the time we compute the duration between the clinic visits and the date of the next appointment, which is usually 90 days, especially for the 3 months, multi-month dispensing or more. So the 3 months is basically 90 days. And when we have been computing the patients that are currently on ART, we look at those who had a visit date but do not have maybe a next appointment date. So if a client has come to the clinic, but then you look at their data and you find that they do not have the next appointment date that is already computed in the system, then what has been done is that 30 days have been added to their visit date so that we can be able to compute the expected appointment data. This definitely could affect the way we have been computing the percentage of clients dispensing, and we'll appreciate if we can have discussions around this. And also documentation of clients in the EMR has been based on categorization and documentation of clients as stable patients. And remember that we had seen that with the revision of the guidelines, please be on the lookout, because they might have a few variations, because initially we were saying that if you're a stable client, then you move to man-to-man dispensing. And so stable clients has basically been what we have been looking at, and whether this stability status has been in the EMRs. So I don't know if your mic, you've turned the computer, so that now we can be able to have the walkthrough of the National Data Warehouse in terms of differentiated service delivery models. I'll stop sharing at this point, and I'm handing it over to you, Dr. Mudoka, if you can hear me, Dr.
Yes, I can hear you. I will use Diana's computer for now. So
okay,
allow
proceed.
So allow me to log into the warehouse, and then I'll take you through a brief demo of the DSD. I want to believe by now the team is aware of how to be able to access the warehouse. The link had already been shared earlier, so I hope people are able to see my screen as well.
Thank you for something.
Yes,
yes, you can see it.
Thank you, and I hope this time around I'm a bit audible. Thank you.
Much better.
So, when you look at the architecture of the new warehouse, the layout, and care and treatment tab, you'll find the DSD tab. For those who have been attending the other sessions, you may notice that we have done most of the other tabs from newly started on ART, current on ART, ART optimization, and also adverse events. So today we cover the DSD, and like the other charts that we have looked at, the standard filters are still there. You can be able to view this data and drill down this data by county, sub-county, or even facility level, or by department. And using these measures, you can be able to understand the performance of certain key programs by these parameters. The indicator definitions and notes have been shared here, and Dr. Ramisi has been kind enough to take us through the logic that we use in computation of this MMP. So for the warehouse, we usually use the duration between the clinic visit date and the next appointment date, and we consider these that are 90 or more to be DSD. But like she mentioned, if some of the dates are missing, usually 30 days. Sometimes this may actually impact on the computation of what we get. So, based on the number that is current on ART as at the end of the year, the proportion that is on MMP would say it's 57%, and this is about 500,000 patients out of almost 900,000. There is a group here that is documented as stable, and for this table, we usually pick from the numbers that are documented in the EMR as stable. You have expected this number to be higher, and the reporting to the was accurate. We also have other categories that may make someone unstable that we have teased out in the trials, and this is patients who are on ART for less than a year, those with HVL, and also those who have poor adherence. Then after that, we have looked at the DSD cascade, just looking at proportion using bar charts of those who are on MMP as a percentage of those who are current on ART, as shown there, and also highlighting the distribution of the various MMP models among patients who are current on ART. You may notice that these percentages may be a bit less than the total number on MMP, and MMP is a computed number, but these standard models or MMP models is based on what is documented in the EMR. So some of these, like the cards that are showing 0, may be an indication of poor reporting or poor documentation in the EMR, as opposed to it being an actual 0, that no one is on that particular model. Then here, to also display the uptake of MMD by documented stability status. So we have those who are documented as stable, and facilities have given a big percentage, about 48%, about 6 months appointment for those who are stable, and a smaller number for those the facilities have identified them as not stable. But when you look at the absolute numbers, majority do not have their stability status documented, and this is evident here. But out of this, again, about 22% of those with undocumented stability status, you can see where we are at about 22%. Then we also have MMD uptake by sex, and not much differences, even though you can see there's a bit of a higher uptake, 34% compared to 31%. So if you are to take more than 90 days, this will be a combination of these two. So this is about 59-60% for this category, and this is about 56% for females, but not much differences. Then after that, we do a comparison by county, just looking at the proportion. Some of this, like in Lamu, is limited because we only have one patient in the warehouse, and this is a function of reporting. So this may not be representative of the situation in Lamu. But the facilities like in West Pokot, Baringo, Nyamira, Nairobi, you can see they proportionally have higher people of an MMD compared to others, Samburu being the lowest. They don't have very few patients because you can see based on the data we have, more than 1,000 patients are not on MMD. Then a similar graph here for comparison by partner, just showing how the numbers change from one partner to another. So from SIS, from KDF sites to as low as Kuringa Stars, almost 5,000 patients not on MMD. Now, I know we've had several discussions with several partners, and I know when you look at the definition of 90 days versus 84 days, some of these may not be representative. When we use the cutoff of 84 days, the proportion will be much higher based on the partners that we have discussed. But in the warehouse, we're using the 90 days as guided. So again, just comparison by age, just looking at whether the age groups and the number of people on MMD, the green color here, is any different compared to others. You can see as age increases, from the warehouse, you can tell that the proportion of MMD is also increasing. Then we also have distribution by sex, just looking at adults from 20 years and above. And again, you can also see the same picture and not much differences between male and female across. Then here, we just want to characterize those who are unstable, just looking at a few characteristics and they're indicated there. And the distribution of the stable patients by county is shown there. And distribution of stable patients by partner is also shown there. So when you have this global look of how the performance is, then you can be able to drill down maybe to a particular county. So for example, you can pick a county of interest. So if I pick a county like CIM, then you can be able to filter this to performance for that particular county. You can even go as far as a sub-county level or at facility level. And then when you're there, you can be able to just measure the performance or uptake of these services in this particular facility. So like I said in the previous meetings, and has been said by several presenters, you can always be able to export the data. If you're making a presentation at county level, you can download as an image and attach it in a PowerPoint. Or if you want to change the chart or look at the data behind it, you can just download it as a CSV or the XLS. Or you can just display a table to just see the data that is used to compute these percentages or the data behind the percentages that is included there. So I'll stop there. And I'll share my presentation again to just make a conclusion of this particular session. So Dr. Ramis, you can share the presentation from your side. Yes, you can move to the next slide. And the next slide to, yes, thank you. So just based on what we have been able to see from the warehouse, I think in terms of documentation at the EMR level, there are stability status and also the different types of MMD models, you will be able to see that it was quite low, and we may need to improve the documentation of this. And like I said earlier, and as we have interacted with several partners,
And as Dr. Ramis has also mentioned, the difference in computation of the logic that we use to classify is on MMD and not on MMD. That may need a bit of consensus because the numbers will not agree if we use different cutoffs. So as we move forward and as we continue to receive feedback, now is to be able to measure the impact of DSD, or just to look at the effects of patients who have been on DSD for a while. And we want to be able to develop extra charts on viral suppression and also retention to see whether they differ by those patients who are not any form of MMD. Let's stop there. Back to the chair. Thank you.
Thank you very much, Dr. Doka, for standing in. You did a good job. And also Dr. Ramisi for standing in for our colleague. From the presentation, I think what has really come out is the issue of, in terms of if we are able to access the data, if we can be able to familiarize ourselves, look at and looking at the DSP section, we are seeing that the data available is able to tell us a story. So if the data available is not complete, or we have some missing facilities, then we might not be able to get the complete story. I may not reiterate much what you've mentioned, but what we've noted is that we have the system, the data warehouse using 90 days, or the computing of the number of days in terms of the logic. If we are going to use 90 days for 3 months retention or 84 days according to the EMR, then it will affect the data that we are churning out. So I think that is something that we can discuss and agree as a team on how to go forward with that. And looking at the charts, I also saw one comment from Dr. Vakil, who also talked about the reason why the data looks low on multi-month dispensing. But I think for the rest of the team, what I want us to really take home from this session is if we are able to really categorize our patients from the stable, the unstable, and the different DSD models, whether the facility, fast track, or standard care. Maybe in the panel session, we'll be able to get more questions and discussions on this so that the team can really be clear on how we categorize DSD and where to put and how to compute the data so that you're able to correctly give the right information. So if there's no immediate reaction currently, maybe we can move to the next session, that is session 2. On the ad hoc section, Mary will take us through the ad hoc section for us to just to understand what it is. I know it's an introduction that will continue as we go forward. We've seen a question from Boya who's talking about who's asking a question on the DSD model. Maybe as we continue with the next session, we can have a panelist answer that question, or we can pick it up during the panel discussions. So Mary, if you can hear me, you can take the next session.
Thank you so much.
Thank you.
Yes, I can hear you very clearly.
Thank
Kindly
you.
confirm you can also hear me. I'm going to
Loud and clear, thank you.
Okay.
Yes. Yes, I can see your screen. You can proceed.
Okay, good morning, everyone. Thank you and welcome again for this session. I'm going to be taking you through the ad hoc section this morning. And we are going to have 2 objectives. I want us by the end of the session, we should be able to, one of the objectives is that we should be able to log in to the ad hoc section, because previously we have been informed that we only require access to access the ad hoc section, because the ad hoc section may contain data or patient level line lists that are not allowed to be accessed by any other person out there. Then the other objective will be to generate line lists from this ad hoc section. So the very first thing that I want us to discuss today is the sign-up process and the administration of the data warehouse ad hoc section. So to be able to, as I've said, you must log in as an authenticated user to access the Addock section. All those users who will not, all those unregistered users will need to sign up first. So today we are going to be looking at two different types of users. One is a user who already has a login, login credentials, and two is a user who has never signed up or accessed the login, who has never accessed the Addock session, or who doesn't have the login credentials. So I'm going to also take you through this from the site, but you see an icon, when you go to the site, you see an icon on the right hand side. We call it the user icon. It has a people's icon, image. I'll show you shortly. So we'll click on that icon, and then we'll be able to log in if you are already a registered user, and then I'll show you the process to log in as the other type of user, that is the new user. So there are some details that the new user will be required to input. For example, a new user will be required to input their organization, their designation, the reason for access, the email address, their phone number, and they are supposed to also create a password. And then there is a captcha provided, and they're supposed to submit this captcha just like any other system that we are acquainted to nowadays. We have the levels of access, the security levels of access being put in place. Then the new user should be able, when a new user clicks submit, they're supposed to go to the email that they have entered and verify, check that email and verify the email address, and then continue. Then at this point, I want to confirm that once that is done, a steward has to validate or grant access. Who is a steward? A steward is a person in an organization who is mandated to manage the users of that organization in the national data warehouse. The steward decides who to grant access to which charts or to what level, to which levels of access in the Addock section. So then a user may also forget a password, just like any other system. Even in your email system, a user can forget the password, and we have availed the forget password link, where I just, now the catch here is the user has to remember the username. The user enters the username and then clicks on submit, and then there will be an email. There will be an email. The user will be required to log into the email and access the reset password from the email. So with that, kindly allow me to go to the warehouse.
As Mary moves to the warehouse, for those people who've clicked on the forgot password, or you have registered an account and you're not able to see the email, kindly check your spam or junk folder to get the notification there. Thanks.
Thank you, Margaret, for that. So how do I access the Addock section? Can you all see this icon here? This is the people's icon or the user's icon that I was talking about. So right now I'm going to address the user who already has the login credentials. So the user who has login credentials will just click on the people's icon and click on login, and I'm sure they know about this, and they will enter their password and then click login, and they will log in. Like you can see on the right hand side, the portal has been able to identify me as Mary, and now I can proceed to the Addock session. So that is simple. How? kindly allow me to, yeah. Okay, so the next user is the user who has no login credentials. The user will click on login on the people's icon first and then login. And then on the right hand side, there will be a sign up, a register now button. Kindly click on the register now button, and then now you see a form for registration will appear. As I mentioned before, kindly enter your title and full name, and you can select the organization just like any other online forms. Some of the information is calculated for you, like the organization, then your designation, and the reason for accessing, and the email, and then the phone number, and the password. Remember, the password has to contain an alphanumeric character, a capital letter, a number, and a number to confirm, and it will actually tell you if it doesn't confirm. Then after that, you will enter the captcha as you are seeing, just to confirm that it is a human being doing the registration, and then you will submit. Once you submit, the next process is that you will verify, the submission will be verified by your steward, because you have selected the organization. For example, if I select Kenya Prisons and I submit as a Kenya Prisons staff, the Kenya Prisons staff steward will receive an email, and they may decide to approve, to grant access or deny access. And you will be notified through the same email that you're going to enter here, and then you may now use that login credentials to log into the warehouse. I'm not sure if I have left out anything. Kindly, if you have a question, kindly ask me now before we move on to the deep dive of the Addock session. Can we move on?
Mary, I think most of the people have gotten, but maybe you'd want to clarify, especially for those who are not registered users, the process. And maybe if maybe not in this forum, but if the stewards, if we can be able to know who the stewards are, and if they're able to support the teams on the ground to do this process that we are learning here. Thank you.
Thank you for that, Winnie. Actually, we started the process for cleaning up the list for data stewards. And after this, we have created a form that we are going to assist you to send us to the partners, so that the partners will input the names of stewards afresh. We noticed that we have various requests for us to change this particular steward, which we are doing on a one-on-one basis, but we wanted to clean up that list so that we have that, the partners know who the stewards are, tell us right now who the stewards are, and maybe I think through our stakeholder engagement capacity building team, we are going to avail that form for the partners. I hope I have answered you.
Thank you. You can proceed.
Proceed. Okay, so allow me to log in, and just before that login, we have, so for the Addock session today, we are going to have two use cases. I hope you can see my screen, the presentation.
Yes.
So
yes,
one of the use case will be, we are going to generate a line list of unsuppressed children and adolescents living with HIV. So it may be, for example, it may be a clinician and a healthcare worker in a facility, and I want to know, for example, in how many children am I having who are unsuppressed using their last biological results. Then the second use case we are going to do is generate a line list of clients who are started on ART, that is 14 days. We will also discuss on how we're going to filter this for any year that a user may want to, and perhaps the clinician, because the patients have already been started on ART, may use this information to make interventions in place so that they make sure that all the patients are started on ART within the acceptable time limit in the guidelines. So I'll just proceed to straight on to the National Data Warehouse. Remember, our first use case is the unsuppressed list of the CAL HIV clients. So I've already logged in. Just like any other links on the portal, click on we are required to click on the Addock section, where you get the Addock section being displayed like this, where we are having a three-step, which is actually a three-step. One of the steps is to view the query. The second step is to view the result, and then the third step is to pivot the results. Before I even start, it is important to say that we have simplified it in such a way that the user, even one who does not have the capacity to do the technical or the big scripts that the data people build the models, to build any script can be able to do, as in the user can be able to execute a query without having to knowing a lot of technical jargons, like I'll show you shortly. So you see on the right here there is a white space, and if you can drag a table from the database schema tree to start building a query. So remember, the first step is building a query. So our database schema here, portal there, I can just click on it on the arrow beside it, like I've just clicked on the arrow beside the DBO, and I hope you can see. Under the database schema, we have the various. Yes.
Mary?
Yes?
Probably it's good to also read the comments. There are some people who are just slightly behind and because this is like our first session and we were just to do introduction, you can just make sure that everybody gets to log in. I can see.
Okay, let's wait. Let's for that.
Yeah.
Let's for that. Anyone having issues with login?
So there's a link shared on the chats, but I think we have those who are not able to log in. They are not able to get the details using the link that is shared. So maybe we can just clarify, especially those who are not registered users, how to go about it.
Okay. Just give me a minute.
Which one? Sasa hivi tuko vyao. Nayo bwana hapa.
So if you can look at the charts, there's the link that has been shared again. Please try it and confirm that you're able to access the site. Thank you. And there's there's some who are waiting for approval.
Okay, so my colleagues are on standby to approve. to make the necessary approvals, and are going to support you even in the course of the presentations.
Wale itakawia sasa. Itakawia mpaka sana. Si kama ile ya mia. Ile ya mia ile.
Okay, so can we carry on, or can we wait for some minutes to allow our colleagues to log in, so that we are on the same?
Maybe we can give it another minute until everyone logs in.
Okay, thank you, Doctor.
I can see approvals are coming in, so we should be good to go in the next few seconds.
Okay, so for today, maybe because the stewards may not be all here, we will require to give you extra support so that we approve some of those requests. But the process is that the steward actually grants access to the user, the steward for the organization.
Mary, you can also advise I can see a concern on the chat that DWH is not listed as one of the organizations. It's missing, so that's a concern from Jessica.
I actually think that one of the things we need to do, we need to clean up the list of the stewards under the various organizations to ensure that that's available. There's a downside today. If approvals are given by Palladium, then some people may be given access to data that does not necessarily, is not under their purview, which may be a slight challenge. So I'm thinking that we could focus on the demonstration process, but also take a step back and work around ensuring that the county teams and the partners who oversee some of these facilities have necessary stewards, and the stewards are able to support the accounts request. Because if I request under EGBAF and I'm given access, we can't validate that I belong to EGBAF at this point. Over.
Yeah, I think that's true, Dr. Chimanga, because one of the things that we had intended to do during this introduction part today was to also train list of the stewards. But apparently, because of the last minute changes, we were not really able to go through that process of training the list of the stewards. Yeah, so I think maybe I don't know what you think. Dr. Chimanga's proposal and we revisit this. Would be okay.
Yes, thank you so much, Dr. Chimanga and Subo. We can carry on with the demonstration of the ad hoc section as the correct stewards grant access to the correct users. And that is actually the guideline. Okay, so I'm just going to start again for the users who had not caught up with us. So after you have obtained your credential, remember you're going to log into the warehouse, and then the system will identify you, and then the ad hoc menu will appear only when you have logged in. So you click on the ad hoc section, the ad hoc link, and you will get what we call the homepage of the ad hoc section, which has the white space on the right and the database on the left, the portal dev DBO. The portal dev DBO contains the database that has the tables, and I have said it is we are only doing 3 steps, and any layman can do is the pivot the results. So the very first thing I'm going to show you is the many tables that are available. So before we start on dragging and dropping, these tables have been modeled. Actually, they have been modeled to various program areas, and the same tables have been used to develop the visualizations that what you are seeing on the portal. So variables have been put together, data elements, and a user can easily use the tables to generate a line list out of that. The reason why we are starting with the name facts, we just fact in a simple demonstration, it just means it has a one row per patient in that table, the fact. But for right now, you're going to see how we're going to group our data. Remember, our first use case was to generate a line list of patients who are unsuppressed, and these patients are children and adolescents who have HIV. So we have again tried to use the naming system that can help the user. For example, anything to do with fact CT, this is fact care treatment, time to ART, we have GRP as a group. For example, fact trust adverse events client, this contains a list of all clients that have adverse events. Treatment out fact trust DSD MMD uptake, this can give an indication by the name, but it contains the data elements that are going to help us in producing a line list of patients who have who are on multi-month dispense. So we are going to use this fact time to ART grouping to develop our first use case, or to generate our line list, that is the unsuppressed clients. We have two ways to do it. We can either drag the table to the right and drop, or we can double click it and it will appear on the right side. So it is simple drag and drop, and then the variables will appear. So you can use your mouse to extend if the table has appeared to be having fewer variables, and you can use the scroll bar to scroll to select many variables. So like right now, I want to use some variables to help me to generate that line list. For example, I want to use the MFL code, I want to use the facility name, I want to use the county, and
inakwenda 08 00
partner, for example. Start ART
44
here is important. So
440 08 00 722 440.
The time to ART diagnosis and the number of patients that I have. The other way, before doing that, you can just come to the table and click on it to just look at which variables are available, to give you an indication of which ones to use, so that you can produce that in your view. So I have selected a total of 7 variables, and if you check down there, what we were avoiding to do is to do the writing of the queries for those users who may not know how to write queries at all. So the app generates for you the code already. And at this point, we have done the first step, which is build the query. We have just selected and the query has been built for us. So we are going to do the second step, which is the view results. So the view result is simple as just click on the view results to just confirm, are these the variables that I wanted to generate? And I can see they are the ones. I wanted to know the time to ART diagnosis, I wanted to know the number of patients and the facility name and the county and So at this point, I have confirmed that this is what I wanted. I'll just proceed to go to the third step, which is the pivoting of the results. So as the data generates, because it's a lot of data, but it has finished now, I want to show you something. You'll see that the app tries to list for you the variables in the white space here. Like for example, it has given us a total of sum of MFL code, which does not make sense. But we have these three fields, these three buttons on the right. One is the format button, the options button, and the fields that are going to help us to manipulate our data so that we generate or we get the output that we require. Let me start with the format. The format button is as simple as Excel. It just formats for us any value of the variable. For example, when we choose MFL code and I say I want it to align it to the center, and I apply, if it was a variable that has numbers that require 1,000 separator, and we also do that. If that was the case. So it's as simple as Excel. I have formatted my variables. The second thing is I'll go to the options button, and then for the options button, I'll need to specify my layout. That is the layout. How do I want my line list to appear? For example, I want my we want to generate a line list, so we do not want to show grand total in a line list. We will uncheck that. Then we want to have it in the flattest form available. The classic form will give us in a hierarchy, but the flat form will give us in a one patient per row kind of layout format. So I'll click apply, and then the last thing I'll do with the formatting of my data is I'll go to the fields, and you notice that the app actually deselects some of the fields that we had earlier selected. So I'll just check all, select on all. We had selected 7 variables. I've just checked on all, and then I'll click on apply. Are we together up to that point? Are we together?
If I can be able to ask, for the most part, yes. If I think there are some who are having challenges and the panelists are supporting them either to log in or just to follow. But for those who are able to follow the presentation, I think we're together. So we can proceed.
So I'll urge the user to just listen into the presentation, because after that you'll be able to get your access, and you can now if you just listen to the presentation, you will be able to do many other analysis even on your own. Okay, so now we have generated our variables, and we have all our 7 fields, and then I can see, like for example, I can order at this point I can do 2 things. First, I can order my list in any order that I want. For example, I can say I want a number of patients to come last. I want here to come second. So it's just a drag and drop of here. Like I can pick this variable and bring it here. Pick this other one and bring it here. And you can see the columns are going to be ordered. Then the second thing that you can do is filter. Remember, we have just clicked on all the variables, and this is all data in the country, all the counties, the facilities. So I may be, for example, I may be a county like Kiambu, for example. I just come to Kiambu. Let me cancel this and show you. There is I'm not sure about the name, but there is a button just next to the variable county on the left-hand side that looks like the settings button. Just click on it, and it will allow us, or it will allow you to filter. They can deselect every other county and maybe select Kakamega County, and then you click on apply. Then remember we want sorry. So we started with the wrong one. We started with the wrong use case. This is the use case for clients who are starting ART for more than 14 days. Remember, this is clients starting ART for more than 14 days. So we have the use cases, and that's why we used the fact, city, time to ART grouping. So I hope that is fine. So we'll do the unsuppressed one right after this. So for Kakamega County, I will want to see clients who have started ART after 14 days. So click apply. And we have this variable.
If anyone asks about
the variable start ART,
the login for data warehouse, tell them we are good enough for stewards who will be approving theirs.
All kinds of start ART.
Yes. The stewards will accept. The steward from the organizations are the ones who will be accepting them after registration.
So like you can again see now I have the facility names to the left, counties Kakamega, and MFL codes, and the number of patients who have been started ART 14 days for those particular facilities. So remember, this
each and every organization has a steward responsible for that.
ART clients who have started, for ART clients who started ART over 14 days. So you can drill down to any facility. This is a facility without
They're clean. They're clean. They're removing all the accounts.
Yeah, they will.
Okay.
We will have the cleanup for stewards. People have switched organizations, so some are not existing. So they will do the cleanup with the new.
Okay. So there is no facility name that has
right now
clients that are.
They must be accepted. They register, send request, steward approves is when they are able to access. Yeah, because now you'll find people are not supposed to access, you'll be accessing these.
Craft interventions, like I say, around ensuring that patients are not starting ART over 14 days. So the other way, because I'll need this data maybe to go and confirm in the facility, I'll need to export it. And how to export is to click the export button and then click the exit. Click export and then I select the format in which I want to export. For example, the Excel, the CSV format. For now, I'll click the Excel. I hope you can still see my screen. There is an Excel file that has been downloaded. And this is exactly the same way we wanted it to appear. So this is the line list that we have generated for patients who have been started on ART for over 14 days in Kakamega County, for example. Is there any question up to that point?
We've been getting questions. Yes, go ahead. Yeah, we've been getting questions on the chat, and also they've been answered so far.
Okay.
So yes, yeah. I don't know if there's any that is missing, but maybe during Q&A we can ask again.
Maybe Dr.
Maybe
just summarizes.
No,
we'll be continuing to show this next week. So if there are any questions, you can still continue to answer them on the chat.
Unachemsha tu na kwanza unaiweka wet fry ama dry fry.
I'll quickly take you through the next use case, which is now the one that the use case for answer press clients. And from our tables, that use case will derive that use case from the viral load. It has to do something. You know very well it has to do with the viral load outcomes table. For example, now, we have 3 viral load outcomes tables, so we will only get that data from the viral load outcomes table. How to know that? We are going to avail a data dictionary, defining where to get what. Just on the Addock section, we'll get a place where we'll fix that data dictionary so that the user does not get trouble finding the data, knowing which tables to actually utilize to get the data from. So from the viral load outcomes table, I'll generate again like 7 variables, the standard ones, NFL, facility code, county, partner. I can decide I want total last 12-month viral load results, and I want the total last 12-month viral load results. And I may also need gender and age group. We can also utilize those variables. It's as simple as the very first thing is select the variable, know which variables you need, then you select them, then you view the results. Then, after viewing the results and confirming that those are the variables that you need, at this point you can go back and reselect and check, either uncheck or reselect. From the build query, you can actually uncheck a variable if you don't need it, then go back and view the results. Then after that, the third point is to pivot the result. Remember, the app will has its own inbuilt capability of analyzing the data, so we don't want the line list in total sum. If we need to format the cells, we use the format cell option. Remember, we are generating line lists today, so we will not show any grant totals. We will use the layout platform to generate the list in its flattest form, and then you apply, and then we select, we actually filter the data. For example, select the high viral load. We want high viral load patients who have a high viral load, and we want adolescents and children. So it is the 1 to 4, 14 to 19, and 15 to 19, and then the under 1 and the 5 to 9. So from here, the user is able to actually export his line list, just the very first one we did, and they can be able again to drill down.
Man City lichapwa jana.
Then use a hero.
I'm not aware about that. I'm going to look at it.
So I'll my colleague Dr.
Hii ni match fixing.
Take it up with
time. Good morning. Yes, Geoffrey. Yes, Joseph.
Can you hear me?
Yes, you can. Dr. Mudhaka, if you're ready, you can take over. And I think Mary, you might want to stop sharing.
Do you have the link?
Thank you. Dr. Mudhaka, karibu.
Okay. So, but you click, if you click the registration, the link, It will take you.
Hello, Dr. Winnie, you can hear?
Register. Just click.
Okay. Hello, I can hear you.
Okay, thank you. I think just to conclude,
Then after you,
what Mary took us through is just a few use cases on things you can be able to achieve from the ad hoc section of the warehouse. And I know one session is not enough, and I know we love follow-up sessions. So some of the remaining use cases, we can be able to address them at a later date. And also the various questions raised, especially about cleanup of the stewards and also access, we can be able to address based on the new information that we receive on the updated list of partners and stewards. I want to stop there in the interest of time and hand it over back to you, Dr. Winnie. Thank you very much.
Thank you. Thank you, Mary, and thank you, Dr. Addock, for that session. I must say, I think this is something new for most of us. So I could see the chats really getting active with a lot of questions. And thank you for the team that has been responding to the questions. As has been mentioned, this is something that this is just the beginning of this discussion.
But when you are registering for this session,
so
so they will be able to filter who is
to follow well. I want to urge you to also be part of the discussion next week so that you can follow. It was clearly mentioned that the main agenda for today's session was just to be able to log in and to carry out the 3 steps in generating line list, which for some of us who have followed, I think we have an idea, and I know with our practice we can be able to get better. Dr. Kimanga actually mentioned what some of the questions that have been coming, especially from the team from MOH, who are talking about not being able to place where they're supposed to log in. So that one, it has been clearly mentioned that the list will be cleaned, and we'll have an updated list of stewards so that you can know a request will go, who will handle the request so that they can be able to approve the login. There's difficulties when it comes to getting the password. I've seen from the chats. The password, I think it needs to be very secure. So it was mentioned that it needs to be alphanumeric and not just probably letters. So we need to probably work on our password so that we can be able to log in, or if we forget, then there's the avenues for us to just look for support. We have a plenary session that is supposed to start, but looking at time, we may not be able to go through the plenary session in detail. But if there's any burning comment or feedback from the team, I'd like to hand it over to Brian to just take us through that in the next few minutes as we wind up. Thank you, and over to you, Brian.
Thank you, Luni. Brian has excused himself because he had another competing meeting, so I will take up this session. And like you've said, because of time, I know most people have been asking questions through the chat, and the panelists have been responding to their concerns and their questions. However, we really do not want to close anyone out. Kindly note that for the ad hoc section, it's just the beginning. We will still have some more of this next week. However, we wouldn't want to close out anyone who may have a question. I can see some hands up. I think I've seen Martin hand was up. I've seen Agnes from Bubu's hand is up. So I would want to request Faith to kindly allow Agnes from Bubu to ask her question. And if there's any other question that you feel you want to verbalize, you can always raise your hand. We will give you very few minutes to ask your question, then we proceed because of time. We had intended to end this meeting at 11, and it's 2 minutes past 2. Yeah, so we can start with Agnes. Faith, kindly give the mic to Agnes and Matthew. Faith?
Yes, I have done so.
Yeah. So go ahead, Agnes.
Agnes, you can unmute yourself and talk, or I can unmute you.
Yeah, so as Agnes and Matthew are unmuting to speak, we'll go through.
I'm around here.
Oh yeah, Matthew,
Hello?
go ahead. Go ahead, Matthew.
Yes, now, my question is only one. The login credentials, how are you going to get them? Hello?
Yeah. Yes, Matthew.
Are you able to hear me?
I can hear you. Yes, we can hear you.
I'm asking about the login credentials. How shall we access them? And whenever we need support, whom we contact.
Oh, okay. Thank you, Matthew. I think that is noted. Yeah, that is noted. Any other? We can take two when we answer them. Agnes, I don't know whether you are able to speak now. Okay. Right. So Matthew's question is how the county teams can be able. Matthew is the CHRIO of Vihiga, so he's asking how they can be able to get in the login credentials to the National Data Warehouse. And Matthew, let me mention that we are always available. Just in case you need any assistance, you can reach out to us on Addock or Palladium, and we should be able to assist you. So, would you kindly respond to one last question? I think that's the only question we have.
You don't have the link.
As I look at the chat.
Can you assist me with your phone number?
Mary? So Matthew, as Mary prepares to answer, I think Mary had taken us through how to do the registration. So there's a form. Once you go to the National Data Warehouse, you can give the password. There's a form that you to fill. So once you fill that form and submit, the stewards will be able to give you the approval. Once you get the approval, you will receive a mail notifying you. Then once you have your password, you can always reset it and you can be able to access the National Data Warehouse. And remember, this is only for the Addock section. For the dashboard section, you really do not need a password to be able to access that. Yeah. So Mary, would you want to add on this, please? Or Dr. Modoka?
Okay, so something.
Pascal's wanted to.
Just
yeah. It's okay, Mary.
Yeah, I just
wanted Pascal.
Sorry, go ahead.
No, I just wanted to respond to the question about how to get support. That there is a toll-free line that has been shared on chat. Mary had shared it on chat. The help desk number that has been shared on chat in case you need any support. So it has been posted on chat.
Yeah, thank you, Pascal. Thank you very much. Yeah, there's that. There's the toll-free number that has been posted on the chat. So now you can always reach out using that number, and you will get assistance. Yeah. Yeah, maybe.
So, can't remember the question clearly. Kindly repeat.
Yeah. The question was how do some of the members acquire the login credentials?
Okay, so right now we are not going to encourage the steward. We are going to follow the process and the guideline. The stewards, they want to approve the request, so the user can register using the register now button as I demonstrated. But in the event they have an issue, they can call our help desk. And if they do not also know their steward, they could also, through the help desk, call and then get to know their stewards, and they can reach them for them to grant them access for now. But by next week, we are going to again avail to you the list of the stewards in the various organizations after we have did the cleanup. Thank you.
Okay, thank you, Mary. So Charity Mongangi, her hand is up. So Faith, and allow Charity to And that would be kindly allow us to make that the last question so that we can proceed because of time, please. Charity Mwangangi, you can unmute and ask the question, please. Charity, if you can hear me, kindly unmute.
So what are over 240.
Okay. As we wait for Charity to unmute, I think we can proceed. We may not really wait for the time. I'm trying to look out if there are any questions on the chat. There's a question from Augustine. For inactive sites in the county, can they be removed from the national editorial so that they don't interfere with our denominator? There's a toll-free line. Okay, for any questions that we may not be able to respond now, what we will do is we can still revisit some of these questions and respond in our next webinar next week. Yeah. So there being no other questions, kindly allow me to hand it over to Dr. Oramisi, who will take us through the next the closing bit. But before then, I want to usher in Faye to just share some few slides that we thought it would be important for us to communicate to the county and the county teams and the subsidiary partners. Faith, if you are ready, kindly 2 minutes, please.
Okay, thank you, Songok. I think we will share this presentation with the most updated version. It was just an update in regards to the median time to AVL at the start of ART. We have disintegrated the data that we did display by ages for you to be able to internalize and figure out what could be happening. So because of time, I will not get to the presentation. Let us just have Dr. Ramisi do the closing session. We will share the presentations that we've done with each one of us so that we can be able to, I saw someone had requested for that. They want us to share the presentation so that they can be able to dive deeper into them and be able to understand them better. So that is what we shall do after this through the normal channel or through the email that we usually do to invite you to this webinar. Thanks, and over to you, Sombo.
Yeah, I think that's a good proposal, Faith. Thank you very much. Looking at the Q&A section, I can see a concern from Douglas Ayoko asking about airtime. So in our last webinar, in the previous webinars, we've not been able to really reimburse the airtime for the county teams. And moving forward from today, be able to try as much as we can to be able to reimburse the airtime for bundles generally. Yeah, so the last kindly note that we were not providing, we were not reimbursing airtime or credit in the previous webinars. But for this one, we should be able to provide you with some airtime to buy bundles. So having said that, kindly allow me to usher in Dr. Oramisi. I don't know whether Dr. Oramisi you can hear me, can close for us. Dr. Oramisi. So probably Dr. Oramisi is probably so Faith, I'll call upon Faith to close the session, to call upon the representatives from the agencies to close for position for us. I think Dr. Oramisi is engaged. So Faith, can you take it up?
So thank you very much, Songok, and I really want to appreciate all of us for participating in this session. And probably before I do the last remarks for this session, I would like to give the opportunity to our colleagues from the from the agencies. So I will start off with the CDC. I don't know that Dr. Kimanga, you're in. Dr. Kimanga, last words.
Thank you, Faith and Songok. Today, as I sit here, I'm very, very excited as I look back to the journey that we began way back in 2010 with the EMR standards and guidelines led by NASCOP, and coming to see that we are seeing the power of individual level data. We even have this very exciting session that we've just covered, that the data that you are reporting is not going into a black hole, but it's then made available to you to really augment the aggregate level reports that you have with the one that comes from this aspect of individual level data. So this is very exciting, and I want to thank NASCOP for the great leadership. I want to appreciate the partner for the great job that they have done over the years. We had a mantra of finishing strong, and everything we are seeing through this is a clear demonstration that this project is actually ending with a bang, and that's a very big plus for all of us. Not to forget the county teams that have played a very key role to bring us where we are today. And even as we start thinking about transition and sustainability, my urge is that we will strengthen this collaboration and ensure that this good work that has been done is able to be available to all of us in the foreseeable future. Very important things that I thought are my key takeaway from this discussion. One is the MMD computation. I note that we have a category that misses their TCA, and as a result of that, there's that computation of 30 days, which may adversely affect that. And I also note the difference in computation, 28 days versus 30 days. And my understanding is that in the next meeting, I would really want us to delve deeper into this so that together we can make a decision and be clear on what we are adopting as a country in terms of moving forward. When I last checked, there was a clear guidance from NASCOP, but we would really want to ensure that this guidance is applied uniformly across. The second aspect is this second thing that we've covered today from the ad hoc section. That was very exciting to see this data and interact with it. But also really want to emphasize the need to ensure that the steward list is cleaned, as Dr. Mudoka said, that at the end of it all, the counties and the partners who are working at the lower level are able to identify the staffs who need access and go ahead and review the application for access and be able to allow them to have that level of access. Remember, the data that we have is still de-identified, but we still want to ensure that we are adhering by the necessary privacy and confidentiality standards moving forward. But we also want to ensure that the data is being used to really augment whatever other reports that you have and allow you to drill down to the lower populations, to the specific regions and the very specific subpopulations, so that you can act on the data and ultimately take us to epidemic control, which is our joint wish. From CDC end, we pledge our support, and we will continue to work with all of you to get us there and ensuring that no individual, no region is left behind in this journey towards epidemic control. Asanteni sana, back to you, Faith.
Thank you very much, Dr. Kimanga, for the wise words, and I think you have done a summary of our presentations from when we started the webinars until to where we are, and I can assure the team there is more that is coming, and we will plan for the next series. So thank you so much, Dr. Kimanga. Henry Damisoni, you can also give us your last words for this session.
Okay, thank you, colleagues. Just to indicate that this is quite interesting, I share most of the sentiments expressed by Dr. Kimanga, that we seem to be seeing light at the end of the tunnel, which is not an oncoming train, fortunately. So from my end, it's also a commitment that we really want this to succeed. And I'm particularly excited to hear this talk of transitioning and aspects of sustainability. Because in all honesty, we have to look back and see what sort of investments have been made, and moving forward, what will it take for us to sustain these gains? So the sooner we engage in that kind of constructive dialogue, the better it will be for all of us. More will come later, but for now, I'm quite excited, and congratulations to the team. Thank you.
Thank you very much, Henry. I think we really appreciate your support towards this venture. And I know UNAID is also geared to supporting our colleagues who do not have PEPFAR support. Probably before I welcome Dr. Ramisi, who's going to close the session, Pascal, you can as well say a word. And I also want to send apologies from Brian Odnyango from USID. He has been on board until 11 when he had to step out to another meeting, but I can assure he's called me and told me he shares the same sentiments with what Dr. Kimanga and Amisoni have said, and USID is ready to support this venture to the end. So I want to appreciate you all, and Pascal, you can as well give us your last words, and then Dr. Ramisi, you can close for us. Pascal?
Thank you very much, Faith, and thank you to all the participants, and thanks to all the panelists today and presenters. I just want to echo the words that have been given by the previous speakers, that this is a big milestone for us as a country, as we are shifting to using individual level data. I think from the demonstration today, it's very clear that this is a paradigm shift. And what I would urge is that as we shift to this new paradigm of use of individual level data, that we focus on the quality and the utility of this data. Only when we shine the light, big spotlight on the data, can we be able to identify the opportunities and the gaps and fix them as we move forward. One thing that I'm really happy about is that for most of the issues that have been raised as either gaps or opportunities for improvement, we've worked together with NASCOP to address them and report back on every subsequent session. So I'm really happy with the partnership that we've had, CDC, USAID, NASCOP leadership, and DOD, of course, to make this a reality. I think we had spoken about the potential of having a series of webinars in the data warehouse for quite a while, but we say better late than never. As Dr. Kimanga said, our goal as Palladium, this Kenya HMS2 project, with funding support from PEPFAR and CDC, is that we finish strong. Finishing strong is what we are doing now is part of finishing strong, to ensure that we are looking at the sustainability concerns, but also the utility concerns. Once the data is collected, how utilizable is it? How well is it being used to inform epidemic control? The number of issues that were raised today, I believe we are going to be able to address them in a subsequent session. One of which is around who can access the ad hoc section. As Dr. Kimanga said, we need to be cognizant of the data governance concerns around it. And for that, then we need to ensure that the data stewards list is updated and that they do provide oversight, some kind of federated oversight of who accesses that data. The ad hoc section is not for all. I think Dr. Vakil mentioned that on chat, because just as we have been presenting previously, the charts that are currently provided without need for any login provide different ways of exporting that data and using it either as Excel or an image or as a table. So in terms of data use already, with what we have done with the enhancements of the protocol, there's a lot that can be done to manipulate, extract, and use the data that is available in the data warehouse. I look forward to the subsequent sessions, especially on resolution of some computational issues that need to be standardized, around 28 days versus 30 days and so on. The MMD discussion, I think that's an area of further discussion. So I really look forward to, if possible, we can have a follow-up meeting next week to sort of have a good conclusion to this first series, and then we can plan for a subsequent series. So thank you very much for the partnership, especially with the NASCOP in preparing for these webinars and having very good participation from different stakeholders. Asante.
Thank you, Pascal, and thank you, everyone. I think as we come to the end, and before Dr. Ramisi closes it up with a word of prayer and her last words, we have the county leadership. Is Dr. Mike still on board? Dr. Mike? Okay, if Mike is not on board, a CASCO representative. I can see Alice. Alice? Yes. Alice, I've given you the mic. You can say your last word on behalf of the CASCOs.
Good morning. Am I audible? Faith, can you hear me?
Yes, I can hear you, but you're breaking, but I can hear you now.
Okay. So on behalf of CASCOs, I want to take this opportunity to thank NASCOP and the partners and everyone who has taken part in this process. Basically, it's a very important and we'll be glad to use it, but as you indicated, it will be very important if we can have all the facilities offering ART and any HIV services, having the EMR system, so that together we can be able to see our data, visualize it, and be able to make use of it for decision making. Of course, there are many things that we need to agree together so that the data become more meaningful and we can easily understand it or comprehend what it means, so that the various confusing indicators can be aligned so that we can be talking the same language. We are glad, of course, we have learned something new today, but it was not adequate, so I'm hoping we can be able to go through the same training so that those of us who could not be able to join can be able to take part in this process. And my very request again to Team NASCOP is if we can have this overview given to CASCOs during the upcoming program review meeting, it would be very important because not all of us are able to join these meetings and stay put to the very end. So if it is possible, we'd be glad to have an overview of this particular training offered to all the CASCOs during our next week meeting. Having said that, then I would want to sincerely thank all of us and thank the team that has been working, tirelessly to have this tool in place. So God bless you and have a wonderful day. Asante.
Thank you. Thank you very much, Alice. Lots of appreciation and for the support from the county teams. I think this far it's been because of our collaboration together. Ole Kempua, I don't know whether Ole Kempua is still on board. If Ole Kempua is not on board, I will request Alice, CHRIO Nairobi, to say something on behalf of the CHRIOs. Alice Kimani. Okay, do we have any other CHRIO on board? All right, so if there is none, I will appreciate you all and thank you for the support this far. And I will hand it over to Dr. Ramisi to pray and do the closing session of the meeting.
Well, thank you very much, everybody, for sparing 2.5 hours to be with us during today's webinar. Very exciting indeed. And we have been able to learn a lot, and we want to appreciate the team that has worked behind the scenes to ensure that actually this gets done, NASCOP and Palladium. And I want to thank you all for participating, UNA, PEPFAR, implementing partners, the county teams led by our CASCOs and CHRIOs, and the NASCOP team at large. Thank you for spending time. And as we had told you earlier, this is not the last webinar. We had thought initially that we were going to finalize with this one, but we'll continue planning for more. And your request for more in-depth analysis, being capacity built on DWP and many other things have all been noted, and we'll work on it. And thank you for asking so many questions. Please keep them coming. Even after this, you can still send us emails, communication to NASCOP and also the Palladium team for us to be able to be supported so that we enjoy using the data that is here. Otherwise, we hope to see you in the next webinar. And I know that you'll all be able to log in, spread the news to others. Let's all be able to join. And let's walk this journey together as the SI family. I am supposed to pray, and I end it by saying that that the Lord bless all of us, and He may watch over all of us until we meet next time. Have a blessed day, and see you in the next webinar. Goodbye from all of us at NASCOP, and thank you.
Amen. That was a good prayer.
Next time, Kimanga should pray.
And
the webinars are over.
No, we have one next week. Kimanga will pray.
No, we need to make them too, so that Shoba also prays the next one after mine.
You will not understand, Sava. I will prepare something.
We respect all religions. Yes, I will pray next week.
The opening prayer will be
guys, bye-bye. You have with us,